Saudi Commission for Health Specialists, for orthopedics, neurologists, internists, family medicine, and general practitioners. For the program of today, we have two scientific sessions. The very first session will be about optimizing neuropathy management with the use of alpha-lipoic acid and duloxetine. It will be presented by Dr. Hani Abdelaziz. Dr. Hani is a consultant neurosurgeon. He's a consultant spine surgeon as well in Sulaiman Al Habib Al Ulaya in Riyadh. The second session will be about the management of osteoarthritis of CISA-DOAs in osteoarthritis management. It will be presented by Dr. Hedi Yunus. Dr. Hedi Yunus is a consultant internal medicine and rheumatology from Sulaiman Al Habib Al Takhassusi in Riyadh as well. I just want to remind all of you that we are happy to receive all of your questions through the Q&A section, not the chat, the Q&A section, to be able to view all of your valuable questions and share it with the speakers to get the replies about it. And I will leave now the floor for Dr. Hani to start our scientific meeting by the very first session with Dr. Hani Abdelaziz. Dr. Hani, the floor is yours. We can start sharing.
Okay, Assalamu alaikum. First, I'd like to welcome all of you. Good evening for everybody, and thank you for being with us during this 2-hour session. And I'd like to thank you all for sharing with us these 2 hours from your valuable time, which is a vacation day. And I'm really happy to see all of you. I hope with this talk, it's a kind of discussion matter, not kind of just giving slides. And I'm really happy to share with you your experience. I'm sure all of you are more experienced in your field more than I, but it's a chance to discuss whatever we see and discuss what you think and to share with you how do you manage these patients. We all agree that the most presenting complaint to the clinics, whatever the clinic is, whether medicine, surgery, or neuro, is pain. And the patient will come to you asking for help to relieve the pain with whatever, from wherever, and what primary condition he's having. He's just seeking help to relieve the pain. So, as we agree that pain is the most common presenting symptom, and in our country, rarely you'll find somebody to come just for checkup or just for regular visit. Most of these patients will come with pain. So, to start with how we define pain, pain is a distressing experience associated with actual or potential tissue damage with sensory, emotional, cognitive, and social components. Just a reminder about the neuroanatomy, and this is a very important slide to start with because this will help me in the later on in the discussion about how to tackle a patient with pain. And as you all know that we have two pathways of pain. We have the ascending coming from the nociception, going through the spinal cord to the brainstem to the brain, where you can localize it. On the other hand, we have the descending pathways, and in between, we have these interneurons to inhibit or facilitate the transmission of pain. Sometimes you can have pain just arising from the central, going to the peripheral without really ascending, just descending. So this is a very important slide to keep in mind and to remind you with the neuroanatomy on which we will build about how to tackle a problem of pain in these patients. So pain can be classified into either nociceptive pain or a neuropathic pain, or sometimes mixed type. And the nociceptive pain, it's caused by activity in the neuron pathway in response to potentially tissue damage stimuli like touching a pinprick, a fire, or irritation of the nerve like disc collapse or any kind of injury like a wound, sickle cell crisis, arthritis, sport and exercise injuries, and mechanical back pain and post-operative pain. On the other hand, the neuropathic pain, it's initiated or causes a primary lesion or dysfunction of the nervous system, and it may persist even after the disappearance of the initiating factor. So it may persist even if you don't find the initiating factor. As an example, like trigeminal neuralgia, central post-stroke syndrome, and as I mentioned, this is one of the issues of the descending pain, that it's really causing central pain. Distal neuropathy, which is the main talk of our talk today, and the neuropathic pain also will tackle this issue. One of the most devastating problems that we face as neuro specialist is the post-herpetic neuralgia, and it's really very agonizing pain, and most of the patients, they are screaming out of it. Sometimes we have what is called mixed type pain, nociceptive and neuropathic pain, and it's combined of both primary injury and secondary effect, like low back pain with radiculopathy, as an example. Now, how to differentiate between the two types of pain? In the neuropathic pain, it's a chronic, while in musculoskeletal, it's an acute pain, which will last for hours or days. But in chronic pain, neuropathic pain, it's usually months or years. And the musculoskeletal or the nociceptive pain is caused by injury or inflammation that affect both the muscles and the joint. In the chronic pain, it's injury or disease of the nerve itself. In the nociceptive pain, it's usually moderate to severe pain that disappear within the injury is level, like you're touching a pin. As soon as you remove the hand or the finger from it, it will disappear. While in neuropathic pain, it will persist even after removing the cause factor. It causes sore and aching muscles in nociceptive, while the cause in neuropathic pain succeeds to touch like what we call the pain, intolerable pain, simply like wearing light clothing is painful, and touching the bed and the bed covering is very painful. And most of these patients will have difficulty in sleeping because they don't know what to do with their hands and their feet, where to put them, and they are worried of touching anything. From patients with nociceptive pain, they have anxious and stress, but optimize that the pain will be relieved soon with any kind of intervention, whether medication or just avoidance of problem. While in the chronic affective pain, because it's a chronic issue, they will become depressed, and they will try to avoid social interaction because they are ashamed and they cannot be relieved of pain. And as I told you, most of these patients, they will have sleep disturbances because they don't know what to do with the pain and what's the best way of relieving it. Now, how we define chronic pain? First of all, chronic pain is defined by the ISAP, that it should be as continuously long-term pain that has lasted for more than 12 weeks. Before that, it's not considered, and it can be anywhere in the body. The back is the most common reported location, but it can happen anywhere. As we mentioned, even chronic pain, it can be neuropathic pain, and it's caused by problems with nerve pathways, which we mentioned in the previous slides, and the ascending and descending pathways, while the nociceptive pain arises from actual or threatened damage to the non-neural tissues like muscles or joint like arthritis, and conducted to the nervous system with pain signaling as nociceptive, and the pathways neuropathic, the spinothalamic, all these tracts. Now, why chronic pain is a very important issue to discuss and to raise, because it carries a burden on the governments and on the finance, because it's more than $6,000 billion cost of chronic treating these patients, and not only medications, not only hospital visits, it's all sick leaves, the non-productivity. So, and if you combine all these patients having these problems, it will be much more than patients with cancer, heart disease, and diabetes combined together. So from this slide, you can appreciate what's the importance of patients with chronic pain, and what's the importance of having this kind of lectures and this kind of multidisciplinary discussion to try to do the best for our patients, and at the same time, save money for the government, and for the not to put extra load on the financing issue. Now, let's go and discuss about diseases with the neuropathic pain. It's either defined as metabolic causes or secondary to compression. And metabolic, as most of you are internists and diabetologists, that the commonest cause of patients with neuropathies are this diabetes mellitus. On the other hand, seen by the GPs and the surgeon is patient with low back pain and sciatica. Now let's discuss about diabetic peripheral neuropathy. As we know, diabetes is really the census are really getting higher and higher, and Africa and MENA region will have the highest progression rate of diabetes mellitus, where there's an increase of around 92%. So it's not only the issue of diabetes, is the consequences of a diabetes, and that's not only to control the sugar, but what are the comorbidities with patients with diabetes. So it's very important to address this issue and not to hide it as just deal with the patient as a blood test of blood sugar level. It's more than that. It's a kind of a lot of comorbidities and complaint of these patients will be affect their life, and they will be unproductive and will affect their quality of life and the quality of even the family that they are living with the patients. Now, what's the definition of diabetic neuropathy? As definition by the American Diabetic Association, it's an agreed simple definition of the neuropathy for clinical practice is the presence of symptoms and or signs of peripheral nerve dysfunction in people with diabetes after the exclusion of other causes. Now, is the most common complication of diabetes mellitus, affecting as many as 50% of patients with type 1 and type 2 diabetes mellitus. Diabetic peripheral neuropathy involves the presence of symptoms or signs of peripheral nerve dysfunction in people with diabetes after other possible causes have been excluded, as I mentioned before in the previous slide. And I'm sure most of you are aware of this clinical picture. Now, diabetic neuropathy, as with other microvascular complication, risk of developing diabetic neuropathy is proportional to both the magnitude and the duration of the hyperglycemia. So that's why the most important thing in these patients to avoid the chronicity, the problems with diabetes, is to have good control and good management of patients with diabetes mellitus. Peripheral neuropathy in diabetic patient may manifest in several different forms, including sensory, focal, multifocal, and autonomic neuropathies. More than 80% of the amputation occur after foot ulceration or injury, which can result from diabetic neuropathy, because as you all know, most of the patients, they cannot appreciate any kind of injury and may injure themselves, leading to ulcerations. Ulceration will lead to infection, gangrene, and amputation. To start with, to avoid this cascade, we have to try to prevent neuropathy and improve the sensation. So what's the pathophysiology? Just quickly, I will not go to this busy slide, but it's very important that with hyperglycemia and dyslipidemia, there will be oxidative stress and inflammation, and that will lead to hexanamine pathways, polyolin pathways, and other thing that will lead to the decrease of prostacyclin synthesis and nociceptive NOS production. This will lead to vascular calcification and collagen deposit, and this will lead to endothelial dysfunction, leading to either macro or microvascular complications. So it's a very complex issue and not just simple issue, and we have to block it at different ways so as to not to reach the micro or macrovascular complications. In this slide, we have that patients with polyneuropathy, whether autonomic, sensitive, or motor, there is affection of the conduction of the nerve sensation, the nerve transmission, and will lead to the either damage and gangrene and infection in the system, and will lead to the neuroischemia, and the neuropathy will lead to neuroischemia if left untreated. Now, staging of diabetic polyneuropathy, it's staged as from N0 to N3. N0, where there is nothing, patient diabetes, but they have no neuropathy. N A1 or 1A is signs but no symptoms of a neuropathy, and 2A symptomatic mild diabetic polyneuropathy, and 2B is severe symptomatic diabetic polyneuropathy, and 3 disabling diabetic polyneuropathy. Our role is to try to catch patient in N0 and maximum N1A, and avoiding these patients reaching the N2 or N3, which is really devastating and affecting the life of the patient. So how to diagnose these patients who are diabetic and having neuropathy? The most important, please listen to the patient. Listen to the complaint and don't ignore a single complaint, because it may starting with a simple complaint of not feeling something to severe disturbing pain. So please listen to the pain. Ask if not mentioned by the patient about anxiety and depression, interference with their life, and sleep disturbances. It's very important to check these points before saying that this patient is N0. So all patients should be assessed for diabetic peripheral neuropathy, starting with diagnosis of type 2 diabetes, and 5 years after the diagnosis of type 1 diabetes. And you need at least annual visit to the clinic to make sure they don't have the neuropathic pain. Its assessment for distal symmetric polyneuropathy should include careful history and assessment of either temperature or pinprick sensation. I know most of us, they just consider pinprick and pain touch, and they ignore the temperature sensation and the positional. Unfortunately, we rarely see doctors who are doing the vibration sensation by using the tuning fork of 128 hertz for large fiber function. So when testing these patients with diabetes for neuropathic pain, it's not only questioning, it's also to do proper sensory examination, including the pinprick and pain sensation, also for positional sensation for joints, and also the vibration and the temperature. All patients should have annual 10-gram monofilament testing in identifying the feet at risk for ulceration amputation. So whenever listen to your patient. Don't take any complaint easily. A simple complaint may affect the life of the patient, and if they ignored, may progress and will come to you later with a second visit with a major complication. And then you have to examine for vascular ulceration, vascularity, hypovascularity, microangiopathic involvement, and also do proper neuro exam. Not only the power, but the most important in these patients is to do full sensory examination for all modalities of sensation. Then locate where is the problem. Then we say, okay, I'm dealing with the spinothalamic, I'm dealing with the nociceptive, I'm dealing with ascending or descending fibers that is affected. Now, the common complaint that patient will come to you is not one modality. He may say to you that I'm feeling tingling sensation in my feet, I have a burning sensation, or I have like electric shock pain, or a shooting like pain. So different way of describing the peripheral nerves in the feet or the hands. Now, let's go to another issue with the neuropathic pain. I'm sure most of the GPs and the family doctors and the neurologists, the neurosurgeon, they face patients with back pain. We have around in the studies that some facts that 31 million Americans will experience back pain at one time in their life. And it's number one of the leading causes for disability and sick leaves in these patients. And so around it's number two, it's one of the commonest cause for seeing and asking for help for the doctor for back pain, which can be either nociceptive pain due to muscle spasm, sprain, or strain after exercise or after doing activity at home, or it can be neuropathic pain, which is secondary to either prolapsed disc, sciatic pain, or peripheral nerve in the joints of the back, as we see in the next slide, or we have a mixed type, which is nociceptive or neuropathic pain. This slide just will sum up the different stages of the disc and the back, and with age, you will go from the top which is the normal disc, to the severely one, which is severely degenerated one. And each part will generate pain either by compressing the nerve, by disc bulge, or by degenerated bone, and this will inflammate and cause a kind of inflammation of the facet joint. At the same time, it may irritation of the recurrent nerve, which is a cause of nociceptive pain in the back and will lead to kind of neuropathic pain, which is described as pain arising from injury or disease directly affecting the nerve roots, either directly as a sciatica or indirectly by affecting the recurrent motor branch, and will give you this kind of dull aching pain of the back. And it's not only the facet arthritis or the joint arthritis, it's also the neuropathic pain from these recurrent motor branches. Now, what are causes of sciatica? The commonest, as known by most of us, is the disc herniation, sciatica, and this will give like pain going with one of the roots. So the patient will either describe like back pain going to the leg down to the big toe, which is going with L5 root distribution. And sometimes it will be piriformis, where the entrapment of the nerve not in the back or the disc entrapping the nerve in the foramen, but it can be as the exit of the plexus from the pelvis in greater sciatic notch, what we call the piriformis syndrome, wherein these patients, especially the patients are sitting on a hard chair for a long time, or drivers on heavy wheel the cars, they will have this kind of hypertrophy of the piriformis syndrome. So why it's important to listen to the patient. If the patient is describing sciatica pain, and by examination you could not allocate proper route, and by doing MRI to the lumbar, there was nothing, that means that the patient is not a liar. This patient is having some kind of entrapment of the nerve in the direction from up down to the distribution of the nerve. So it's your job here to see what's it's a single root or it is multiple. And piriformis syndrome, if it's really typical like a sciatica with normal lumbar spine MRI, so looking to the MRI pelvis. And it's very important, these patients, if normal MRI lumbar does not exclude sciatica, you have to look for the pelvis MRI, and you have to insist for our colleagues in the radiology department to do a proper study for the pelvis, and not to look to the content of the pelvis, but to study the piriformis. Sometimes you need to do EMG studies and nerve conduction to pick up this kind of condition. And even MRI will not be able to pick it up, but EMG will say to you that there is entrapment of the nerve in that area, either in the pelvis or the piriformis, and the exit of the nerve from the sciatic notch or in the thigh at other sites. And also, another cause of sciatica is the common injection in the buttock for the IM injections, which is very commonly done in the clinics by nurses. And they, instead of going far lateral, they go a little bit medial, and by that, either going direct trauma to the nerve or by chemical irritation to the nerve if giving some kind of medication roughly. And will that lead to sciatica? And the best way to diagnose is by clinical examination, listen to the patient, looking for positive of any kind of injection to that side, and EMG. And the other issue is trauma, whether they're going downstairs, the patient will fall down and in a sitting position and will have a direct trauma to the buttocks while either playing soccer or playing any kind of games, who have direct trauma to the buttock area that may disturb the nerve function and will lead to sciatica. Now, some facts: sciatica will affect up to 40% of the population in their lifetime, and the incidence will increase with age. Complication may lead to nerve damage that may lead to weakness and loss of feeling. So the patient may come to you complaining of numbness of the feet, or not feeling the foot or the big toe, or having difficulty in moving the toe, or having foot drop. Sometimes it may even affect the nerves supplying the bladder, and the patient will come to you with sphincteric control problems, and unable to pass urine, or the other hand, unable to control urination. The risk factors is obesity, going with age, occupation, and the most important is diabetes as a combined effect of the nerves, either direct compression or by metabolic compression. What are the causes of the sciatica? Either herniated disc, bone spur, lumbar stenosis, irritation of the lower spine, or degeneration with aging. What are the symptoms? If it is in the, as I told you, in the joints and all that will be dull aching, but the sciatica, the common sciatica complaint, they would have sharp or burning-like sensation going with the distribution of root. So the patient will tell you that I'm having back pain radiating to my lower limb, and he will pinpoint the direction. And if you ask the patient to show the direction of the pain, he will be able to draw a line which goes with the route that is affected, either it's L5 or L4 or S1. And if it's leaving for a long time and compression of the nerve, that may lead to paralysis of the nerves, will lead to foot drop or some kind of weakness and decreased sensation. What kind of modalities, whether it's pain, decreased sensation, or thermal or positioning. Now, let's go to the management, and I'm sure here I would like at the end, if we open the discussion, to discuss how we treat patients with the neuropathic pain. Today, we will focus on the pharmacological management. I know management of neuropathic pain is a multidisciplinary, and if you focus on medication, you are missing like 70% of the proper way of managing these patients. But to keep with the scope of the talk today, we will just concentrate on the pharmacological, but keep in mind that we have a lot of other issues to start with, like psychological, physical, and exercise for the patient, including yoga, swimming, all these patients. We may go for pain modulation strategies. We can go for surgery, as we see in the coming slides. Today, I will concentrate on the pharmacological and concentrating on two subtypes. So it will not be a full talk because we don't have time. It's beyond the scope of the talk today. Now, when treating these patients, either we do pathogenetic treatments or we do symptomatic treatments. In pathogenic treatment, we have to tackle inflammation and oxidative stress. If you remember the first slide about the pathophysiology of pain, and we find that the primary issues of having neuropathic pain is caused by inflammation or the release of oxidative stress. And in this case, we use treatment of the underlying condition by giving the vitamins, giving anti-inflammatory process, or giving the alpha-lipoic acid that we'll give more talk about it today. So this is the pathogenic, and usually we start with these in early stage patients, whether the case it's either diabetic or metabolic cause or cause of compression. And here also it can be go for surgery for decompression if needed, if the patient is having compression of the nerve, and the best way is to decompress the nerve wherever the site is, whether disc or compression of the femormis or in the thigh. On the other hand, it's the symptomatic treatment, and this is the where most of our patients are in that corner, where they have a lot of symptoms. That's why they come to your clinic with a lot of pain and affecting their lives and their productivity. And here we can use the neuropathic bone modulators like the gabapentinoids, and the sertraline norepinephrine release inhibitors. That one will give more talk about it. To start with the pathogenic treatment is to talk about the alpha-lipoic acid. Now, the good news is that alpha-lipoic acid is produced in our bodies. So it's not something from outside. It's something, the body will produce it to counteract any kind of damage or problems. And the common daily consumption by ALA, by food, is relatively low in order to achieve a healing effect. So we produce it, but not to the amount that it's used as a pharmacological, but it's an endogenous factor. So it's not something from outside. We have it in our body. So not to worry that we are using something dangerous or something outside like other medications. And it's naturally found in the mitochondria and like as an essential cofactor for mitochondrial respiratory enzymes, such as the ketoglucuronate dehydrogenase and the pyruvate dehydrogenase. It's also required for the oxidative decarboxylation of pyruvate to acetyl-CoA and it's a critical step, as you all remember, in bridging glycolysis and the citric acid cycle. So ALA have been suggested, ALA is a abbreviation of alpha lipoic acid, have been suggested as a powerful antioxidant since it scavenges the free radicals, chelating metal ions and activating endogenous antioxidant defense system with a powerful capacity of regenerate the oxidized forms of vitamin E, C, and glutathione. So in this slide, as we can see, alpha lipoic acid, it can work as antioxidant, as I mentioned, and it's a strong inhibitory effect on NF-κB activation, which is tumor necrosis factor and hydrogen peroxidase. Also, lipoic acid is a potent inhibitor of age-induced NF-κB activation, preventing protein glycation, and it's a lead to a significant increase in brachial artery flow, mediated vasodilatation, and reduction in plasma levels of interleukin-6 and the plasminogen activator. So it is a multifactorial effect we have with this drug. And as I mentioned, it's endogenously produced, but not a sufficient amount. Now, I know most of you, they would like to depend not on experience, but on evidence-based medicine. So I will go with you through this kind of studies that will prove the effect of this kind of medication in patients with diabetic peripheral neuropathy to start with. This is a critical appraisal of the use of alpha lipoic acid in the treatment of symptomatic diabetic neuropathy. In this study, analyzed data from 1,160 participants in different centers, so it's a multi-center study in Aladdin, Sydney, April, Sydney 2, and Aladdin 3 trials. And the conclusion that ALA in oral usage of 600 milligram daily administered for up to 5 weeks could have a benefit and symptoms and signs of diabetic neuropathy without significant side effects. So these 4 studies have good, strong evidence-based evidence that this drug may help these patients in treating the painful or beginning of neuropathy. So if patient having early stage of diabetic neuropathy, I would advise to start with medication based on the study to prevent them from going to stage N3 or N2B. So a patient with even N0, it's nice to start as prophylactic treatment so as not to progress, plus treating all the comorbidities and proper control of the sugar. So it's not only a single drug, it's as I call it, it's a multi-task treatment. So it's treatment of the underlying causes, comorbidities, proper control of sugar, and for peripheral neuropathy to start with this medication. Another study by Nahas, and this study is done in Saudi Arabia. And so why doing this study from Saudi Arabia is that to see the population, these are our population, and this is the combination of patients who will come to your clinic and not depending on studies coming from Europe or other countries with a different ethnic background. And as we can see that the total symptoms improvement in all of these studies done at different areas. So in conclusion, alpha lipoic acid have a satisfactory effect on neurological and other diabetic symptoms. That was the conclusion from all these studies. Now, let's go for another topic using the alpha lipoic acid in chronic back pain and sciatica. Also, evidence-based study where it's used by radiofrequency, and this study was done in Egypt, where they did radiofrequency in treatment of chronic back pain, especially patients with facet joint disease or black disc syndrome and neuropathic back pain. Unfortunately, most of us as a surgeon, if patient come to you with chronic back pain, looking to the MRI, saying there is no nerve completion, most of us in the past, we used to ignore these patients and think that these are malingers and they are just coming from sick leave or attempts to take medication. But as I told you, listen, and locate, you'll find these patients are real sufferers and it's affecting their life because of the severe neuropathic pain component of these patients with chronic back pain, and it's really affecting their life. So in this study, They are treated with radiofrequency at 32 Celsius for 120 seconds at the site involved with the recurrent motor branch. And they added in group 1 inflammatory acid treatment. We'll discuss at the beginning 3 times a day for 3 weeks, and then kept a maintenance dose for twice a daily for 2 weeks. As we can see, this is group 1 and this is group 2. And we have they have collected 120 patients, so it's not a small number. And so they concluded that pain score significantly decreased at 3 and 6 months, and improvement in disability score at 6 months without any significant side effects. So they postulated that oral supplementation will help us to reduce the progression of the nerve pathology via its anti-inflammatory action on the affected nerve. So in this kind of treatment, which is combined modality, think, as we'll see in the next slides, that these patients with the neuropathic pain, a lot of time you need to have multimodality treatment, as I'm sure most of you agree with me. So using radiofrequency alone showed that lower efficacy in adding alpha-lipoic acid because of anti-inflammatory process of this medication and the nerve regeneration and prevent further damage to the nerve. Now let's go to the other issue, which is symptomatic treatment. And as you all agree with me, most of the patients will come to you in this stage where they have symptoms and it's really painful neuropathy. Rarely you see a patient coming in the early stages, and you are here caught with a patient who's in pain and asking for help. And he is affected badly in his life, in his work, and with his family, and he is away from social activities. We have a lot of drugs in the pocket, and I'm sure you have used over the time most of these drugs. I'm sure most of you are aware about gabapentin and pregabalin, but nowadays we have this kind of restriction of using these medications, and with Rapib, it's really tough life to prescribe for a patient with all its side effects. We can use opioids, tramadol, and also it's a kind of restricted drug. Also, for a long time, we used to use the tricycline antidepressant, especially amitriptyline. And now what I'm really proposing is the serotonin noradrenaline reuptake inhibitors, which is duloxetine. And going with the coming slides to see the proper tolerance of these drugs than the gabapentin and pregabalin, and the proper management of these patients with less side effects and more pain control. So antidepressants, as we used to use for a long time, the strength of this drug is strengthening of the inhibitory pathways of the pain control and achieved by inhibition of the reuptake of monoamines into the nerve terminals. So these is the main work of antidepressants. Serotonin and norepinephrine, it has a direct effect and indirect effect. For serotonin, the direct effect through the synapse between the descending pathways and the afferent second order neuron. While the norepinephrine, they have the direct effect in the synapse between the descending pathway and the afferent second order neuron, the same thing. Indirect effect is activation of the opioidogenic inhibitory interneurons, activating the GABA acidinergic inhibitor interneurons for norepinephrine. This is just the first slide that we started. That's why I started with this slide in the beginning, just to remind us with the anatomy, and by understanding anatomy we can apply pharmacology, and as we can see that there are a lot of interneurons in between, and we can play with these and modulate these by using the anti-epileptic drugs like gabapentin, sodium channel blockers, the antidepressants, and the ketamines and the cannabinoids in the descending pathways, while the inhibiting the ascending ways is by using the non-steroidals, lidocaine, and capsaicin, local cream or patches. So this is the, just to remind you, where we tackle the pain pathway and how to improve our understanding of the pain and what's the best way of doing this kind of management of pain in these patients. I'm sure most of you will come to me and asking that duloxetine, patients are not happy. The patient have showed some adverse events. That's why they stopped the medications. I would like to assure you that with this study is that the most common nausea, it's common, but it's usually short-lived. And only we see it in 25% of our patients. And most of them are short-lived and it's mild. Um, so how to see and how to tackle, I will show you this patient is how to try to avoid this complaint to assure the compliance of the patient with the medication. The good news is that nausea occur usually in the first week of the treatment and resolve rapidly with continued treatments. The median duration is 5 days. So ask the patient, tell him about this complication before starting, tell him about this side effect. He will tolerate it and he will accept it and later on will disappear. Again, back to evidence-based medicine and duloxetine and diabetic neuropathy. Well, this one is there's a study about double-blind, placebo-controlled randomized studies in about 1,139 patients, and we've seen there's a kind of different dosage of duloxetine, 20, 60, and 120. Unfortunately, we don't have in COD 20. We've seen used in patients with diabetes type 1 and type 2 who are having painful diabetic neuropathy and not it's like into A or into B or in 3. And that have it for at least 6 months duration, around 24-hour pain severity, moderate pain severity, a fixed dose trial 12 weeks. And as we can see from this slide, that there's dramatic response of the pain on the different patient with different dosage. The best one is when using the treatment dose or therapeutic dose 120, but still with 60 you see good improvement. With smaller dose, there's improvement not as much as the therapeutic dose. This slide is a very important and really encouraging to all of us as a physician that using duloxetine in patients with diabetic neuropathy, there's dramatic improvement in the outcome and in the physical activity and function. Just concentrate on this one where they have improvement on the physical function and the social activities compared to the placebo when using duloxetine into 60/2. And this slide is really encouraging that these patients will be back to life and not will be as sufferers. Now, comparison of efficacy and safety of duloxetine and gabapentin in diabetic peripheral neuropathy. It's a meta-analysis that's done. The objective of this study was to do meta-analysis to compare the efficacy and safety of duloxetine and gabapentin in the treatment of diabetic peripheral neuropathy, and therefore to provide evidence-based medicine for clinical treatment. It's a 7 studies meta-analysis. As we can see that there is a compare between duloxetine and gabapentin, and the blood spot that diabetic neuropathy treated with duloxetine, the different slots and the improvement and all these patients. To start with, of adverse side effect, duloxetine was better in having less side effect than gabapentin. The response rate is much better in duloxetine compared to gabapentin. And sometimes you need to have a higher dose of gabapentin to reach this effect. So with a smaller dose of duloxetine, you can reach the effect of gabapentin of higher dose. So in conclusion, it confirmed that duloxetine has advantage in the treatment of diabetic peripheral neuropathy, providing a reference value for the resection of medication. Duloxetine is worthy of clinical promotion and may have a promising application prospect due to its convenient medication, less side effect, and good safety. As we all know, when comparing the anticonvulsant treatments, they have a lot of side effects on the white PCs and the dependency with the pregabalin. So in this study, duloxetine was compared to pregabalin for diabetic peripheral neuropathy patients with suboptimal pain response to gabapentin. So these patients were already on gabapentin, but they were not responding well. So what to do with these patients? The patient will come to you that he used gabapentin and he reached to full dose, and then you have to think of shifting him to another modality of treatment. And group one, they have used monotherapy duloxetine. And the second group, they have used duloxetine plus gabapentin. And the third drug, they have shifted him directly from gabapentin to pregabalin. Also, it was compared using these patients, comparing pregabalin comparing to duloxetine, who are having also antidepressant. And it was found that patient with non-antidepressant duloxetine showed a higher effect in pain management than pregabalin. Well, the antidepressant treatment users, they are almost the same, no much difference. So duloxetine was superior to pregabalin in pain reduction in antidepressant non-users medication starting 4 weeks after the medication is initiated, and maximum dose through the last visit after 12 weeks. So as we can see, if patients are using antidepressant, the response to duloxetine is much higher than pregabalin. So in conclusion, duloxetine was associated with a better pain reduction than pregabalin after 4 weeks of treatment, who switched from gabapentin monotherapy and were not on antidepressant. Conversely, switching to duloxetine or pregabalin may provide similar reduction in pain properties already on antidepressant. So here we are talking about different potential. If the patient is not on antidepressant, I would advise to go to duloxetine and not to go for pregabalin. Now let's go to another issue about duloxetine uses in chronic back pain and sciatica. This study shows the effects of the duloxetine in patients with chronic back pain. Not talking about short period, it's a chronic back pain. And duloxetine was used from 60 to 120 once daily and showed significant reduction in the pain and the greater movement and function compared to patients with placebo with the chronic back pain. Pathological analysis demonstrate that the improvement in back pain index, 24-hour average pain, and because of the direct analgesic effect of duloxetine treatment, and not dependent on the improvement of the depression and anxiety symptoms. So it has a direct effect and not secondary effect. And on the other hand, it's well tolerated with all side effects, as we mentioned before. Now, I'll take these 2 slides as a guideline and hope we end discussing these proposed 2 guidelines. This is neuropathy management guidelines by different societies, the American Diabetes Association, the International Association of Pain, and the American Academy of Neurology, and the Pharmacologic Management of Chronic Neuropathic Pain. They all agreed that the first level of therapies in these patients is to use pregabalin, gabapentin, and duloxetine. They all agreed that complementary medication, non-pharmacological, is alpha-lipoic acid, and also to go for exercise like 4 hours a week with a maximum heart rate of increase of 50 to 85. Second level is tricycling antidepressants, valproate, lidocaine patches. And the third level is the topiramate and the acupuncture and yoga. So as a conclusion in this, that the first line of treatment for all these 4 associations, they recommend to use gabapentin, pregabalin, and duloxetine as a first line of treatment. Plus the alpha-lipoic acid, all they agreed that it's the line of treatment as non-pharmacological treatment, or the not symptomatic but pathogenic drugs. Now, screening, diagnosis, and management of diabetic sensory-motor polyneuropathy in clinical practice, international expert consensus recommendation. This is a very important slide, although it looks busy, but it's easy and simple. Just go to the blue boxes. Patients who are asymptomatic, mild to moderate diabetic sensory polyneuropathy, which constitute around 50% of our patients. In these patients, advised to go for pathogenic-oriented medications, the alpha-lipoic acid, as approved and agreed by the 4 associations. If the patient is symptomatic, but it's non-painful, like paresthesia, numbness, sensory disturbances, but still he's not complaining of this kind of burning and otonesia and painful sensation. Here you go, alpha lipoic acid, which is beta-adrenergic treatment, included medications. Now, the most devastating is the third one, which is painful sensory diabetic sensory polyneuropathy or peripheral neuropathy. Then we have to go for symptomatic treatment. And in here cases, we can go for duloxetine and pregabalin and gabapentin, plus the non-pharmacological options. Continuation of the slide. So once we diagnose symptomatic diabetic peripheral neuropathy, if there is any contraindication and comorbidities, start with the monopharmacotherapy, either gabapentin, tricyclic antidepressant, and the serotonin norepinephrine receptor inhibitor, most likely duloxetine we are talking here. If the pain is relieved or partial response, then consider contraindication and comorbidities to increase the dose. If not, then we have to go instead of monotherapy into combination therapy. If no pain relief or intolerable side effects, then switch to other monotherapy. So go back to square one and change your medications to another medication. Combination pharmacotherapy, we can use Tramal, duloxetine, and tricyclic antidepressant, gabapentin, and gabapentoids. And if there is a maximum tolerable dose, if pain is controlled, and it's okay. But if the pain is not controlled well, then think of adding strong opioids and capsaicin. So start with monotherapy. If you cannot reach the maximum dose, think of combination therapy. If it's still in pain and the patient is not responding, then go to the opioids. If still with full dose, using all strong steroids, and the patient is still in pain and is not responding, then think of surgery. The commonest mode is treatment is the spinal cord stimulation or deep brain stimulation. But usually these patients will stop at stage 1 monotherapy. Some will go to combination therapy plus the ancillary treatment like physiotherapy and yoga. And a very minimum amount we go for spinal cord stimulation and surgical treatment of these patients. So this slide really sums up the management guidelines in the clinic, and this is a consensus and like from expertise that was distributed, and this is the feedback, and that's what we got from the treatment. Now, just a quick review about German Diabetes Association. More or less is the same. You go for one treatment, pathogenic in early stages, asymptomatic if they are pain-free, and if well tolerated, then increase the dose. If untolerated, you count for combination therapy. So more or less as the one we have it before. So monotherapy, if unable to go to the full dose, think of combination with decreasing the dose of each one. Still no response, add strong opioids, and there's still no response, go for surgery. The American Diabetes Association standard of care in 2026 that the certain norepinephrine reuptake inhibitors include duloxetine and other medication, and they have 2 high-quality studies and 5 medium-quality studies support the role of duloxetine in the treatment of pain and diabetic peripheral neuropathy. High-quality studies support the role of venlafaxine in the treatment of pain in diabetic peripheral neuropathy. Only 1 medium-quality study support the possible role of desvenlafaxine in the treatment of peripheral neuropathy. Adverse effects have been severe in older population, but may be attenuated with lower doses or slower titration of duloxetine. So this slide just add up that duloxetine, whenever starting it, start with a smaller dose and build up dose gradually. So start by 30 and to reach the therapeutic dose to have it. And as the International Association of Pain Management, they have considered duloxetine as the first line of treatment beside the gabapentin and the pregabalin. But as I mentioned, that the side effects of duloxetine is much lower, especially if you first discuss the issue of the side effects of this medication with the patient and titrate the dose from lower dose at night to a higher dose and gradual building up the dose. Also titrate the dose according to the lifestyle of the patient. If he's a night worker, different from a daytime worker, and usually start with the weekend dosage so as to avoid the somnolences that may happen, nightmares that may happen, nausea. So may start with a weekend night dose or evening dose instead of night so as to avoid nightmares, smaller dose, and build up gradually to reach the therapeutic dose, which is 60 to 120 milligram. So, pharmacological management of chronic neuropathic pain, the Canadian Pain Society consensus treatment in 2017. The first line of medications for the management of neuropathic pain are the gabapentin classes of anticonvulsant, tricyclic antidepressant, and the serotonin noradrenaline reuptake inhibitors like duloxetine. The quality of evidence is high for the serotonin noradrenaline reuptake inhibitors and gabapentin group in the treatment of neuropathic pain, moderate for tricyclic antidepressant. So again, the first line of treatment here is the serotonin noradrenaline reuptake inhibitors and gabapentin superior to tricyclic antidepressants. This is a very busy slide, but I will go to the just last issue about this is a summary of the dosage for each medications and the side effects and the additional information that you know about each medication. The scope of this talk and the time limit is just, I will show that with duloxetine, the advice is to start with a smaller dose and increase every week till you reach the therapeutic dose and titrate the timing of the dose according to the lifestyle of the patients. Thank you very much.
Thank you very much, dear Dr. Hani. It was a very informative session. We received a couple of questions in the Q&A section. I'll start by the very first one from Dr. Khulud. She's asking about how can we do the microfilament test for the diagnosis of diabetic neuropathy?
Well, as we start, it's not only this test, this one. It has to be a combination of testing. So to start with, most of us in the clinic we go for just simple testing that is he's feeling pain. But so you have to go for pinprick, for thermal, for positioning, and then the EMG will help you in diagnosing that.
Okay, the second question from an anonymous attendee. He's asking about the alpha lipoic acid is manufactured as what? I think he's asking about the dosage forms available for the alpha lipoic acid. What is the trade name? Do it have any side effects?
Well, part of our obligation with the Saudi Commission, we cannot give trade names.
Yeah.
But it's like alpha lipoic acid. If it be between us, I can send you an email and ask the company to send you an email, but we have to stick to the rules of the Saudi Commission not to give any promotion or any advertisement for any kind of generic names. So I apologize for that. But it's called the scientific name is alpha lipoic acid. And I depend on Christine to give him the generic name. The dose we have is the Science 600. And in Saudi, we have something different from what's available in Jordan, but it's all the same name of the patient. And I think it's the same company. Am I sure, Christine? The one you to export to Jordan is the same as you export to Saudi, but under different names, right?
Eva Pharma does not export to Jordan, but we export to other different countries in the Middle East with the same name of the trade name. But we can answer the question of the dosage form. The dosage form available from alpha lipoic acid from any company is the tablets or the capsules. And we can answer that if it has any side effects.
To tell you the truth, I haven't encountered a little bit from some discomfort like gastric upset in the first week. That's what I have seen. And most of the patients, they are not much annoyed by it. So just proposed when to give it with food and to avoid especially with the fat saturated food, then yes, they will be fine. And not to take it on a fasting stomach. That will help you in decreasing that side effect.
Exactly, doctor. Another question from Dr. Khulud. She's asking about gabapentin for renal impairment and renal failure dose.
As I told you on the scope of this talk and the time limit, yes, it needs to be adjusted. It was mentioned in one of the slides that it has to be adjusted. And as I mentioned, if there's contraindication of full doses, then you have to go for combination therapy where you can use optimal dose, and you have to do like renal adjustment according to the stage of renal impairment. Is it early, moderate, or severe, or end stage dialysis? And accordingly, there are charts that you can refer to, and you can adjust the dose as the clearance and the kidney function, and adjusting the dose accordingly.
Exactly, dear doctor. Effects of these medications is the question from Dr. Hussein. I think he's asking about the gabapentinoids, duloxetine, the slide that contained the symptomatic therapy.
You mean this one? This is some of the common adverse effects. I don't know if you can see the slides. Is it showing?
Yeah, you can
Christine?
see the
Okay.
slide. Yeah.
With gabapentin, as I told you, because of the time limit, I was not unable to go over these. It was just an idea of showing the different medications. With gabapentin, as we all know, it may cause drowsiness, dizziness, peripheral edema, and visual blurring. Pregabalin, dizziness, the same thing, drowsiness, edema, visual blurring, and the most important issues is it may cause headache, ataxia, nausea, and some skin rash. And the like with the carbamazepine, which is rarely used in these cases. Now, for pregabalin, the main problem with the pregabalin is the high dependence rate. So that's why you have to be very careful in the dosage of these patients compared to the gabapentin, where you can use high dose safely from 300 to 1,200 dose safely without the dependence effect. With the pregabalin, you may tip the balance to dependence, and it's really very, very, very difficult to get them off the dependence, especially even sometimes with smaller dose like 150 twice a day can get your patient to dependence, not necessarily to reach 300. So the main disadvantage of pregabalin is not the drowsiness and the dizziness, is the dependence, and it's really hard to take them off these kind of medications. For duloxetine, as I mentioned, it's mainly nausea, constipation, ataxia, dry mouth, and usually it's a self-limiting. It's 1 week, most of these patients. And as I told you, it's better to tailor the dose with a smaller dose, 30, and increase it gradually to reach the therapeutic dose. And the timing of the dose and the starting medication, I would advise my personal experiences to start for weekends, at evening or at night, to avoid the effect of sedation and nausea, and not to have it on the stomach in the early morning. By that, you can decrease the side effects.
Okay. Another question, after starting duloxetine, when do we expect to see actual effects regarding the pain level?
Okay. As I mentioned in the previous slide, usually it will take time to reach the dose. So starting with a smaller dose is just to build up the dose. And to build up the dose, you will take around 4 to 6 weeks to build up your dose according to the tolerance of the patient. But usually you start feeling some improvement of this patient after 4 to 6 weeks, not before that. So if the patient start the medication, tell him that from the beginning he will not feel improvement in the first couple of weeks. So he will be angry from you that I use medication, I'm still having numbness, I'm still having pain. You can just reassure them it's not a magic drug. We need to build up the dose till we reach the therapeutic dose. And here is different. Sometimes you have to reach 120 to reach a therapeutic dose. 160 is enough. So to start seeing effect, it's around 4 to 6 weeks when you reach really therapeutic dose, not before that.
Okay, another question from Dr. Zain. Dr. Zain is asking if you personally think that alpha lipoic acid has an efficacy on the treatment of neuropathic pain as an experience-based.
To tell you the truth, I'm experienced. I used back at home in Saudi. I'm really facing a problem with the insurance. Some patients, they don't like to pay. I discovered real dramatic improvement in post-carpal tunnel surgery. To tell you the truth, I used to give each patient with carpal tunnel to trust the medication like 1 or 2 weeks before my surgery, sometimes 2 weeks, most of my patients, and I do the surgery, keep it for at least 1 month to 2 months, and I found in a study that it's not published. I'm going to publish it, but here I'm following my patient. It's still not published. Is that the outcome of patient with carpal tunnel surgery? The outcome is much better in pain post surgery than patients on no medication, alpha lipoic acid. To tell you the truth, so yes, I have good experience, and I used it in back at home, and especially carpal tunnel, which is surgery. And that's one of the main problems where they have really proven evidence that these patients, they have compressive neuropathy and severe pain interfering with their life. And as you all experience as a surgeon, that some of these patients, if not an acceptable percentage, they are not happy the first couple of months after surgery of carpal tunnel, especially if the severe form, which most of our patients will come to you with severe carpal tunnel, with wasting of muscles and weakness. The outcome using this medication and the pain reduction is much higher than using just surgery alone. So yes, I do have experience, but not in back pain only. I did it with carpal tunnel.
Okay, last question. About any precautions about alpha lipoic acid in hepatic patients.
Well, as I mentioned, if there is no contraindication, when you talk is a patient who doesn't have any other contraindication. And liver, yes, you have to be very careful because it bypasses that liver. Although the company would say no, but I personally be careful whenever I have a patient with liver problem, renal problem, or any other problem is to use this medication. Especially, like, for example, using pregabalin in patients who are having varicose vein and peripheral vein insufficiency. Although not mentioned in the books, but I personally take it very cautiously whenever having any other comorbidities in using drugs. So that's why sometimes I use combination drugs to avoid full dose. Yes, I do agree. Look for any comorbidities and adjust your dose accordingly. Even Panadol, and these patients having liver failure, you cannot use paracetamol. It's not safe. Or Relaxon is unsafe.
Exactly. As per the book, as per the evidence and clinical trials, no need to make any dose adjustment. But as per the experience, you may need to make that adjustment as per Dr.
As I
Hain.
told you, the company there's no contraindication, but I don't take the chance of fixing. So yes, I will try to avoid. Although the companies were trying to convince me that it's safe, like with paracetamol, it's safe. That you need high dose. It's just a simple drug, safe drug. Same thing with alpha lipoic acid. I'm a surgeon. I'm a doctor. I'm really very cautious. All these comorbidities.
Thank you so much, dear Dr. Hani. We have finished all the questions in the Q&A.
Thank you very much.
It's
Thank you
time
very
now
much.
to leave the floor for Dr. Hadi Yunus. Dr. Hadi
Okay.
is a
Well,
consultant
just mainly to have a
internal.
chance to thank you, Christine, and the Ava Pharma company for all these great effort to doing this kind of event and this kind of meeting. So thank you very much. Really appreciating your effort, and I know the work that you've done over the last 2 to 3 months to make this event alive, to the truth, because I know it's not easy to gather like 700 participants in a meeting on Friday afternoon where everybody's sleeping or taking dinner or taking food with family, going out. So thank you very much, Christine, and if I can be.
Thank you so much, Dr. Hani, for your valuable words.
Thank you.
Thank you. It's time now to welcome Dr. Hadi. Dr. Hadi is a consultant internal medicine and rheumatology in Sulaiman Al Habib Hospital Al Takhassusi in Riyadh. Dr. Hadi, the floor is yours.
Good evening, everyone. Thank you, Christine. I'd like to thank also Ava Pharma for the invitation for the talk today, and for thank all the attendees as well. I'll try to share the slides from my side.
Okay, Dr. Hani, we can stop sharing for Dr. Hadi to start.
I'm trying still here. Done. I think.
Great, thank
Yes.
you.
Thank you.
Thank you, Dr. Hani, as well for the excellent talk as well. I hope to meet you soon.
Hoping so. Soon.
I'm trying to. Okay.
Dr. Hadi, you are viewing your email?
Yes. Now the slides, I think you can see the slides.
Can see the slides بس يعني هي مش باينة كلها. هي zoomed in أوي.
This is how it's showing from my side.
Okay.
Can you see it? Is it clear?
This is better, yes.
Okay. So good evening again, everyone. Thanks, Eva Pharma, again for the invitation for the talk, and all the attendees for making the effort for today's lecture. My talk will be pretty straightforward. We will be talking about osteoarthritis, some statistical data, some to show the burden of the disease. We will talk about the pathogenesis briefly of osteoarthritis, and we will end with some focus about the role of diacerin in the management of osteoarthritis and the studies supporting the role of diacerin in our daily practice. So osteoarthritis, as we all know, has a huge burden worldwide, economically, on the healthcare systems all over the world. We can see in this graph there it varies between different regions in the world, and the numbers, if we go into details, as we can see, again, this is the contribution of different osteoarthritis. Again, is basically divided into the types affecting the knees, the hips, the small joints. We will talk about this later during the slide. So, to mention some numbers, in 2020, approximately 7.5% of the global population, or about 600 million people, imagine this number, lived with osteoarthritis. And this is an increase from 4.8%, or about 256 million in 1990. So it almost doubled within 30 years or more. Among individuals aged 30 and older, 15% approximately had some form of osteoarthritis, with a notable rise in prevalence among working age adults. What about the future? It's estimated that in 2050, the numbers will increase significantly, whether it is for knee osteoarthritis, hand osteoarthritis, hip, or the other types of osteoarthritis. So this shows that it is the problem is huge, and it needs to be addressed from different aspects. What about the etiology and risk factors for osteoarthritis? Osteoarthritis, it's becoming more and more understood nowadays, but still we still have lots of gaps in knowing the exact pathophysiology or pathogenesis of the disease. But in general, it is a complex disorder, or as it's a spectrum, as we sometimes refer to it in our daily practice. It has genetic and racial factors that play a role: gender, age, hormonal status, bone density, nutrition, muscle strength, obesity. All these are considered as constitutional, put the patient at a risk for osteoarthritis. Some mechanical factors or biomechanical factors, like joint shape, joint alignment, joint laxity, trauma, the occupation, the sports done by the patients, all these put the patient at risk for developing osteoarthritis with time. Again, if we go into some numbers, for example, in the US, this slide shows some data from the US. About 30 plus million US American adults have osteoarthritis, with the estimated $80 billion cost in terms of lost work or earnings per year attributed to osteoarthritis. It puts about $2,000 average person per year in medical costs. 1 in 3 veterans has arthritis, compared with 1 in 5 civilians. 23.7 million have difficulty with performing daily activities due to their joint arthritis and osteoarthritis. And 40% of adults with arthritis are usually inactive. And this has consequences, again, when we link it to metabolic syndrome, obesity, diabetes, and heart disease. So the burden of the disease is pretty huge, and it puts lots of stress on the economy and the healthcare system and healthcare facilities as well, including the nurses, the doctors, operation rooms, etc. So again, this is what we just mentioned. If we try to link obesity to osteoarthritis, there is a very clear link between these two entities, particularly at the weight-bearing joint, mainly the knee. For example, one systematic review found that obesity increased the risk of osteoarthritis about 3-fold. Again, a systematic review of 25 studies, which used varying definitions of hand osteoarthritis, which is common in our clinic and daily practice. We see lots of patients with hand osteoarthritis. And they calculated an approximate relative risk of obesity and the development of hand OA to be 1.9. So obesity puts the patient at the high risk for osteoarthritis of the knee, of the hand, and even it's considered as an independent risk factor specifically for first carpal metacarpal osteoarthritis. So obesity and osteoarthritis, very strong correlation, and the connection is very, very clear, very well established. What about diabetes as well? In individuals aged above over 50, osteoarthritis also may be concurrent with diabetes in about 10 to 15% of the cases. So again, these are two very common medical problems. We see them in our clinics, and the connection is pretty clear. With the numbers, for example, in the States, about 26 million adults with prediabetes have arthritis. Cardiovascular relation to osteoarthritis, again, whether it is, it's very, very, very clear, this correlation. Patients with osteoarthritis and heart disease, ischemic heart disease, all these are interconnected with each other, especially from the metabolic point of view. So patients at risk for cardiac events, ischemic heart disease, heart failure are usually diabetics, are usually overweight, they have metabolic syndrome, and it puts them at high risk for osteoarthritis. What about articular cartilage structure? We all know that the structure of cartilage is pretty complex, and it is basically it's a mix of collagen fibers, chondrocytes, proteoglycans, and all these are playing among each other to prevent the development of osteoarthritis. This is in the normal joint. So, for example, collagen fiber sheets, they provide the high tensile strength to the cartilage, and they prevent or resist extension and protect cartilage from swelling pressure generated by the proteoglycans. What are the proteoglycans? Proteoglycans, as we know, are large, high molecular weight molecules and consist of what we know as the chondroitin sulfate, the keratin sulfate, and hyaluronic acid. And these play a role in attracting water to make a hydrated tissue that resists compression. What about chondrocytes? Chondrocytes are mature cartilage and cellular manufacturing sites. They produce and maintain the surrounding matrix. So all these are playing a major role in preventing the destruction of the cartilage, articular cartilage. And here comes the role of inflammatory mediators, such as the interleukin-1, which plays a very pivotal role in osteoarthritis. So mechanical stress then drive these chondrocytes to produce less functional collagen type 1, smaller and less space-occupying proteoglycans, more nitric oxide, and additional interleukin-1, leading to loss of articular cartilage. And eventually, chondrocytes fail to maintain the balance between synthesis and degradation of the extracellular matrix. So we need to try to inhibit or limit the inflammatory mediators and interaction in the joint itself or in the level of the articular surface. And one of the newest molecules that are dealing with this interleukin-1 specifically mediator is diacerin, which is the focus of our talk today, as we will see in the coming slides. What about radiographic features? We all know that osteoarthritis, there are several radiographic features associated with joint space narrowing, bone spurs, bone cysts, etc. And just keeping in mind that the severity of the images does not always correlate with the severity of the symptoms. So some symptoms might be severe despite non-severe imaging on X-rays. We move on to the management of osteoarthritis. Osteoarthritis management is pretty complex. There is a role for pharmacologic, again, and non-pharmacological treatment modalities. And it's really different between different patients. Although, as we mentioned, it is a single entity, osteoarthritis. In clinical practice, it's usually a spectrum. We have the mild forms, the moderate forms, the severe forms, and as I tell my patients, no two patients are the same when it comes to osteoarthritis. What about the management? As we mentioned, there is a role for non-pharmacological modalities, which starts from patient education, heat and cold compressors, weight loss, occupational therapy is very important, unloading in certain joints, physical therapy, which they help us a lot in managing our patients, long-term walking and resistance training programs, Tai Chi, acupuncture, electromagnetic field stimulation, bearing in mind that each of these modalities have different levels of evidence and support from different scientific societies. So the floor is, the discussion is pretty wide when it comes to non-pharmacological treatment and when it comes as well to pharmacological treatment. Now, the treatment is pretty complex for osteoarthritis. We all know that we have the simple treatments of NSAIDs, topical NSAIDs, oral NSAIDs, steroid injections. We have the role of chondroitin sulfates, hyaluronic acids, PRP recently. All these have different, again, levels of evidence supporting the use of each of them. With some of them, despite being used commonly, different societies have conflicting opinions regarding their use. When it comes to chondroitin sulfate, for example, hyaluronic acid, steroid injections, etc., etc. We will focus on a new modality. We call them the SISA-DAOs. And these are symptomatic, slow-acting drugs for osteoarthritis. This is an important class in the pharmacological treatment for osteoarthritis, and that are demonstrated to alleviate the symptoms of pain and functional impairment, with additional evidence of a disease-modifying effect in the long term. So basically, this is what we really would like to achieve with our patients. We need a disease modification in the process of the disease itself, not only pain and symptomatic treatment. And this is very, very similar to what we see in rheumatoid arthritis or psoriatic arthritis, etc., where we use disease-modifying drugs that prevent the progression of the disease and inhibit the process of the inflammation itself. And the European Society for Clinical and Economic Aspects of Osteoporosis, Osteoarthritis, and Musculoskeletal Diseases, what's known as the SQA, recommends using cisadose as step 1 pharmacological background therapy with paracetamol as add-on rescue analgesia when needed. So diacerin, the focus of our talk today, is one of these cisadose, as we call them. It has anti-catabolic and pro-anabolic effect on cartilage and the synovial membrane. So it prevents the destruction and favors the building of the cartilage surface. It is an anthraquinone derivative with anti-inflammatory activity against the IL-1 beta. So by preventing the IL-1 beta activity, it's calming down the inflammation and suppressing it, and hence preventing the worsening of osteoarthritis. Now, the main question is, do we have any data regarding the role of diacerin on osteoarthritis? Yes, we have some studies which show the benefit of this drug. We will go through these studies briefly. The first one was trying to assess the ability of diacerin in slowing the progression in hip osteoarthritis. So they checked the decrease in joint space width of the hip. And this was a randomized double-blind placebo-controlled 3-year study. 507 patients with primary osteoarthritis of the hip, as defined by the ACR, American College of Rheumatology, received diacerin 50 milligrams twice a day versus placebo. And this was published in the well-reputed Arthritis and Rheumatology Journal. And the results were as follows. The demonstration of a structure-modifying effect in hip osteoarthritis is feasible. This is the conclusion of the study. And shows for the first time that treatment with diacerin for 3 years has a significant structure-modifying effect as compared with placebo, coupled with a good safety profile. So there was a positive result in terms of preventing the worsening of hip osteoarthritis or radiographic changes in the hip X-rays with a good safety profile. Another study showing the efficacy and safety of diacerin in the treatment of knee osteoarthritis. The method was a meta-analysis of randomized placebo-controlled trials, and they wanted to see if diacerin had any efficacy in treatment of knee osteoarthritis. The results, again, the conclusion was diacerin might be considered as an effective drug for treatment of patients with knee osteoarthritis, showing short-term residual effectiveness, although it was associated with an increased risk of diarrhea, and this event is mostly tolerable. And this is really something that we see in our clinics. Some patients report mild diarrhea, which is transient. Again, in the Journal of Rheumatology, another study, it was an international multi-center double-blind randomized study. It's called the DISCO trial. And it studied the effect of diacerin versus celecoxib and NSAID on the symptoms in knee osteoarthritis. So the pain and symptoms were the primary endpoint. And it showed that diacerin was non-inferior to celecoxib in reducing knee osteoarthritis pain and improving physical function. Again, it was shown to be safe in terms of side effects, and it therefore confirms the positive benefit-risk ratio of diacerin in knee osteoarthritis. What about the recommendations of the ESCEO committee or group? It showed that diacerin has a similar efficacy compared with NSAID on osteoarthritis symptoms. It has an acceptable safety profile when it comes to other treatment modalities, especially NSAIDs and paracetamol. Remembering that NSAIDs chronic use has lots of side effects in terms of renal failure, hypertension, etc., which are effects we would not like to see in our patients. And they position diacerin similar to other cisDAOs as first-line pharmacological background treatment for osteoarthritis. So there is a role for diacerin in the right group of patients with osteoarthritis. So by this, I would like to end the talk about diacerin and osteoarthritis in general. And I would leave open the floor for any discussion. Thank you all.
Thank you, dear Dr. Hadi, for the presentation. I would like to encourage all of our attendees to drop any question in the Q&A section for Dr. Hadi and Dr. Hani as well, if you still have any questions for Dr. Hani as well. Till then, we have one question for Dr. Hani, asking about if there is any specific plan for post-herpetic pain.
Yep.
You can see me?
Yes, we can see you, Dr. Hadi.
Sorry, can you repeat the question again?
Okay, it's a neurological question for Dr. Hani about if there is any specific plan for post-herpetic pain. Till we receive questions about the diacerin. Dr. Hani, can you hear us? Dr. Hani,
I can hear you, but I cannot.
Hani and Hadi, we are confused.
I can. I'm not able to. Am I? You can see me?
Yeah, we can see you. Okay. And we have a question for you from Dr. Khulud about if there is any specific plan for post-herpetic pain.
Well, first, let me thank Dr. Hadi. And it's a long time I haven't seen you, Hadi. So really appreciating, although I'm a neurosurgeon, but I'm really interested in your talk. I really get benefit a lot. Really, I benefit a lot. Because, you know, we have a lot of patients who are coming with peripheral neuropathy and carpal tunnel, and they have conjunction osteoarthritis of the hand. So it was really beneficial to me, to tell you the truth. And that's the thanks for Eva again for combining two kind of specialties in the same talk. Now, go back to post-herpetic. Yeah, it's a very devastating disease condition. And we have here to stage our patient. Where is he? Is he in the acute stage, or in the demolished phase, or in the neurogenic? First, with post-herpetic, we have to prevent. Now we have, thanks God, we have vaccine for that. So I would encourage any patient who's above 50 to see the family doctor or his doctor for vaccination to prevent the treatment. As you know, herpes zoster is a dormant infection. And once you got it, it will be lifelong unless you are treated properly with first, if you can prevent it, then if we can treat. So whenever you have a patient with herpes, having herpes, don't take it lightly. He should be treated aggressively with the antiviral treatment. He should be followed up for any chronic pain. And these patients who are having chronic pain, they are in a very bad and severe pain. I hope none of us will have it. It's very bad. Now, yes, we can go, as I mentioned, we can go to treatment with monotherapy, antidepressant. Usually it doesn't work in antidepressant. Here, duloxetine is used, pregabalin, but what I would suggest and recommend, as in my practice, these patients, I go for nerve block to start with. I go with multimodality. First, I treat the infection. I treat the pain with the pain management, like as I mentioned, but at the same time, I'm having low threshold to send him for our pain clinic specialty for giving nerve block for these patients. Most of these patients, they end up with multimodality nerve block and some kind of monotherapy, and it's really good. But you have to be very aggressive from the beginning and not to wait till the end and go slowly. You have to be very rapid and hit hardly at the beginning, not like the other drugs. You hit hard. Sometimes you do nerve block with medication, not wait for medication to fail. Start your monotherapy that you can start as early as possible, the nerve block, and then you can go for even surgical ablation for that after that. But most of these cases, nerve block with monotherapy is enough to treat.
Okay, thank you so much, Dr. Hani. For Dr. Heidi, I hear a lot this question, which is about the
Yeah.
usage of Dicerine versus NSAID.
Mm.
Should we stop NSAID or we can add Dicerine on the NSAID?
Yeah. In my practice, we add them like Dyson is an add-on. It's not. I don't use it as a treatment for pain or symptoms mainly. I use it as a disease-modifying drug. But the results vary. We have to be realistic. The results vary depending on the stage of osteoarthritis. The results might be more prominent in the mild to moderate cases, not in the severe or advanced cases. And there's no problem with combining them with NSAIDs. But of course, the NSAIDs story, we need to be careful with NSAIDs. We don't like chronic use of NSAIDs due to the side effects that we all know about. So I try to limit NSAIDs usage as much as possible. Use Dicerine. Also, there is a role for supplements. I call them supplements. I wouldn't call them as treatments because the guidelines don't go much. There's no much evidence behind using them, like the chondroitin sulfate, hyaluronic acid. So we have to tailor our therapy based on the patient's profile and case by case.
Okay, we have another question about, do I take it long term or in cycles? What happens if I stop?
Mm-hmm. That's an important question. Like we get it. How long am I gonna take it? Now, in the HIP trial that we just mentioned, it was studied over 3 years. But we don't have a clear guidelines for the duration of using the medicine. Really, I usually give it based on the patient's response. Some patients are happy with using it. Some patients may say, "Well, I didn't find any improvement." So we discuss it with our patients. We need to hear what they say as well. But in general, is a 3-month, 2 to 3 months course would tell us, is it helping or not? And based on that, we can decide, are we gonna continue or look for something else?
Okay, and also the good news is that Dicerine as a molecule has a residual effect. So after stopping it, it will still have its effect for some time after stopping it. Okay.
I had some patients even reporting getting less headaches, less muscle pain. So, you get different side effects or desirable side effects.
Maybe this is due to its mechanism of action being a potent anti-inflammatory.
Exactly.
Interleukin-1 beta inhibitor. Another question asking about at which stage of osteoarthritis Dicerine be effective and the effective dose regimen.
Yeah, so we have to remember that we are talking from, as rheumatologist or internist, we are talking from the medical point of view. So the cases we usually see are the mild to moderate cases of knee pains, the early cases. We're not talking from the orthopedic or the surgical point of view. They might have some different approaches. So in these cases, usually the dose is once or twice daily. 60 milligram once or twice daily, and as we mentioned, up to 3 months as a start, and then we assess the response on case by case.
Okay, great, doctor. As per the SMPCs of the product, the dosing regimen is to be taken once daily for the very first month, the very first 4 weeks, then to upgrade to the second or twice daily regimen for Dicerine. Another question asking about geriatric patients, if it could be used in, and as per the SMPCs, I have to highlight this, that for patients 65 years or
Yeah.
older, diaserine could not be used. Another question, the duration of treatment in osteoarthritis generally.
Yeah, we mentioned depends on the patient. If you want to see an effect, we need to take it for a few months, at least 3 months, and then we reassess the benefit, the side effects, and we decide if we're gonna continue or we're gonna stop the medication. But in general, it's well tolerated, no reported side effects. In general, it's a safe medicine.
Exactly.
Now, in the elderly as well, we need to be careful about polypharmacy, and so we try to give the necessary treatments and try to be careful about drug interactions in general.
Yes, exactly. But as per the SMPCs, it's written that for patients 65 years or older, it's not recommended to be
We
taken.
need to be careful. Yeah.
Okay, another question is about, is it effective in cervical and lumbar spondylosis?
We don't have data really on this. As far as I know, we don't have data about these special cases. But the main focus is hand, osteoarthritis, knee, and the hips. We have the data, some of which we shared already in the slides.
Exactly, the hip and knee osteoarthritis mainly. Another question is asking about why not to be used in elderly above 65. I can answer this as because it's an anthraquinone derivative. It causes diarrhea, so that patient population has a risk of having diarrhea. So we are afraid of the regulatory authorities are afraid from the dehydration that could be caused by this diarrhea.
Dehydration.
Another contraindication is the hepatic impairment. But for the renal, it's okay to be taken until being a severe renal impairment patient. We can take it.
I think it should be avoided in patients with renal
impairment as per the SMPCs
or liver.
For the mild and moderate, no dose adjustment, they can take it. For the severe, we have to divide the dose by half, so it could be taken once daily. For the renal, for the hepatic, it's not.
It's contraindicated.
Okay, another question asking about the role of glucosamine and omega-3. Mentioning the supplements.
Yeah, this is a question we always get. Well, there is no based on the ACR, the American College of Rheumatology. There are no. These are not recommended. Although they are, we use them in daily practice. These are not put in the strongly. They divide them into strongly recommended modalities of treatment, weekly recommended, not recommended, or against. So these are put in the not against them, but they are not recommended. So because of the benefit is limited based on studies and established data. Some other societies, I think, they push more for using them, but for example, the American College doesn't push much for using these, unless they are talking about the injections, or is it about we are talking about glucosamine and the chondroitin sulfate, or the hyaluronic acid?
They are asking about the glucosamine and the omega-3. So I think the oral formulations.
These are not highly recommended.
Okay. They highlighted that it's oral.
For example, the hyaluronic acid injections, for example, in the knee, they are conditionally recommended against, for example. So the recommendation is based on which joint are we talking about?
Yes, which active ingredient?
Which ingredient or medicine we are addressing. Yes,
exactly. We have answered all the received questions. Thank you, dear Dr. Hadi, for that beneficial discussion, and Dr. Hani for the valuable present CME. And also, I would like to thank all of our attendees, the 700 attendees that were with us throughout the CME today. And stay tuned for more and more CME waves from Eva Pharma. We may have another CME very soon, inshallah.
Okay.
So stay tuned for our news. On behalf of
Thank
Eva
you all.
Pharma, thank you so much, Dr. Hedi. On behalf of Eva
Thank you all.
Pharma,
Thanks.
I would like to end this meeting and thank all of the attendees, speakers, and staff for making this happen. Thank you so much.